Good morning. I'd like to thank Rima for giving me this opportunity. And this is one of my favorite topics, fundus fluorescent angiogram in posterior uveitis, when it is required and when not. At the beginning of my career, I used to do the fundus fluorescent angiogram. ICG was not available, not that OCT, and made a lot of diagnosis with fundus fluorescent angiogram alone. So let me start with a case. And this is a 40-year-old man, no pain, redness, gradual dimness of vision for 3 months. Fundus showed yellowish-white lesion in the subretinal space. Over the blood vessels are going over it. Now, do you need an FFA in this case? Of course, it could be choroiditis or not. That's the dilemma. You need it was not a choroiditis. It was multiple leak CSR. You can see the point leaks over there in the early phase, and the late phase is increase in the fluorescence with leaking or pulling of the dye. To me, this is one of the most important indication of FFA in posterior uveitis. This is a patient who presented with scar in the macular region with a little fluid over it. And what is the cause of the CNVA? If you do a fundus fluorescent angiogram, you could find out the punctate hyperfluorescent spots all around the CNVM, and this is indeed a punctate inner choroidopathy with CNVM, which is quite common to have CNVM in punctate inner choroidopathy. And this is a case which you see in Indian subcontinent quite frequently, retinal vasculitis involving mid-periphery and with retinal hemorrhages involving multiple quadrant. Do you need FFA? Yes, you need an FFA to find out the capillary non-perfusion and this veno-vena shunt tortuosity of the veins will all tell that this is dealing with a case of Eales disease, which you used to call earlier. Now you call it tubercular retinal vasculitis, and you can see multiple retinal neovascularization. And this you cannot many times miss your indirect ophthalmoscopic examination. And you can also find out the cystoid macular edema even post-photocoagulation. This is a 30-year-old man, gradual dimness of vision, MANTU positive, and this is a choroidal lesion is seen over there. And what it is, initial fluorescent angiogram, hypofluorescence, but if you go into the mid and late phase, you see an halo of hyperfluorescence in, which is a typical ring of fire in TB choroidal granuloma. So morphologic appearance and the fluorescent angiogram appearance will help you to come to a diagnosis. This is a 66-year-old male with gradual dimness of vision, MANTU negative. Serum ACE was elevated. You can make a diagnosis of sarcoid choroidal nodule. But if you do a fundus fluorescent angiogram, you will see the initial hyperfluorescence and late hyperfluorescence, smooth hyperfluorescence, which will indicate that this is probably dealing with choroidal lesion of sarcoid choroidal nodule. This is a patient, 20-year-old female, complained of sudden scotoma, flu-like fever 1 week back. And fundus examinations, you may or may not be able to see the white spots in the retina. And these are evanescent white spots. If you do a fundus fluorescent angiogram, early stage itself, you will see the hyperfluorescence, wreath-like pattern, and this will help you to make a diagnosis of what you call multiple evanescent white dot syndrome. ICG can supplement the diagnosis. And this is a picture of fundus fluorescent angiogram and corresponding ICG. This is a patient where I feel that fundus fluorescent angiogram is quite required. 20-year-old female presenting with the blurring of vision for 6 months, and she had SLE. And if you don't do the fluorescent angiogram, you can miss the gross capillary non-perfusion, and this patient promptly required photocoagulation to prevent neovascularization. And this patient did have neovascularization of retina, neovascularization, and successfully photocoagulated, and we could preserve the vision. And this is a patient, 20-year-old male, gradual dimness of vision, no pain, and you can see that multiple exudates and there is a vascular abnormality. But this can elegantly be demonstrated by fundus fluorescein angiogram, beading of the vessels, optic nerve head aneurysm, and these patients is very important to do a fluorescein angiogram because they can have gross capillary non-perfusion and they can develop neovascularization. More obvious case is a case of a VKH where you can make a clinical diagnosis quite often. But fundus fluorescein angiogram will support the diagnosis having pinpoint static sky pattern of fundus, high pinpoint leak, and which will be late phase pooling of the dye in the subretinal space. And this can be seen in bilaterally in other eye, also almost similar picture. And of course, is the early multiple pinpoint leak, mid and late pooling of the dye in the area of SRF. And now with the OCT, you can see the basilar retinal detachment and basilar detachment as well as the subretinal septi, which is quite characteristic of Vogt-Koenigsegg disease. And this is a patient of Behçet's disease where you can make a clinical diagnosis quite often, but capillary farning is quite frequent seen in this case. Almost always you see the capillary farning indicating a very severe internal inflammation. So this is a capillary farning as you've seen in that capillaritis, this capillary inflammation over the lesions. In case of serpiginous choroiditis, you can do fundus photography as well as the autofluorescence, but fundus fluorescent angiogram will show typical age will be hyperfluorescent and central area will be hypofluorescent. Autofluorescence is very helpful in such cases to find out whether the disease is active or not, the extent of the disease, etc. This is a 39-year-old female, complaint of dimness of vision, 5 years, vegetarian, no history of animal contact, base-corrected visual acuity 660, 612, blood count normal, peripheral smear eosinophil count was normal, and this patient has a scar in the foveal region. And we did a fundus fluorescent angiogram. You can see the hyperfluorescent lesion, and this is a beading appearance, which is the track of the worm. And this is what we call diffuse unilateral surrogate neuroretinitis. And this has been seen over the area, over the OCT. And there is the complications, which are that one, here is a case of choroidal scar, and you can see this bleed with the little SRF, and we see that fundus fluorescent angiogram late first showed the membrane over there, which is hyperfluorescent. In case of cystoid macular edema, if we are able to do a fundus fluorescent angiogram, you can see the petaloid hyperfluorescence, and this can obviously be seen with the optical coherence tomography. So in summary, the FFA is required in several situations for diagnosis to differentiate between the CSR and choroiditis to determine the extent of involvement, to follow the disease process, and to identify the complication. Thank you very much.